Welcome to our very first One Health+Tech meeting in Edinburgh. It's very exciting. We thought we'd start off by just introducing ourselves as the sort of organising team. We'll start with Katrin.
Right. Hi, I'm Katrin Creswell from the University of Edinburgh, Director of Innovation in the Usher Institute, social scientist by background, and I research innovation environments and digital health, healthcare implementations, I suppose. So, Michael. Oh.
Nice.
And I don't sleep because I've got 2 little kids, so.
Hi, my name is Michael. I'm an A&E doctor in NHS Lothian, and I also work as a clinical fellow at the Digital Health and Care Institute in Glasgow.
Thank you. And I'm Catherine Stables. I'm going to try and get this to clip on again. I'm a postdoc at the University of Edinburgh in the Centre for Cardiovascular Science. And I'm a data scientist in a sort of loose sense of the term, interested in innovative ways of collecting and analysing and using data to improve healthcare in cardiology, but in a broader, applicable to other fields as well. So we're just going to start off by sort of thanking our sponsors. So Digital Health and Care Institute are the main sponsors for tonight. Thank you very much, whoever's here from there. Product Forge, the amazing Product Forge, are live streaming for us, which is brilliant. Thank you, guys. And have helped out with other AV and lots of things. And the University of Edinburgh, who are providing the space for us to be here tonight. So that's good, thank you. So I thought we'd start by just sort of introducing what One Health+Tech is, because probably most of you hadn't heard of it before. I hadn't before I got involved. So the central theme is to use the power of communities to drive change in digital health. And what does that mean? Well, basically, One Health+Tech started out as actually a women's network in health tech, but has now sort of expanded to just encourage all forms of diversity. And the idea is that by driving equality, everyone will benefit from the best healthcare. And I think what attracted me to sort of get involved in this is the idea that of two ways in which that sort of diversity is so important to trying to innovate in healthcare, especially in the NHS. One is the idea that if you can get more women and minorities into higher up level positions in industry and academia and the NHS, you are bringing in more voices, more ideas, and that can only be a good thing, obviously. But also the idea of diversity in terms of breaking down silos of people. That was sort of the other aspect that really attracted me, I guess. It's really easy to sit inside your own environment, whether that's in an academic environment within your own department or in industry, in your sort of where you sit, the people you normally network with. But if you start to break down those barriers and actually communicate well with other people and talk to people, talk to patients, talk to the academics, talk to industry, I think there's a huge amount of power in that to help improve how we are able to innovate and really boost that, basically. So that's why I think One Health+Tech is a really good movement. They're also really a very cool bunch of mainly women, I have to say, because we started out as a women's network, but all sorts of people are involved now. Who are really fun. They're really organised, which is very useful. So they've really supported us in setting this hub up, which is brilliant. To introduce actually their background a little bit more. They were established in the end of 2015, and they've got 11,000 members at the moment. They have hubs, they have hubs in Bristol, Leeds, Liverpool, Manchester, London, Dublin, Cardiff, Cumbria, Edinburgh now, and Cambridge coming soon. And they've got some international ones coming as well, you can see up there. So the model is this community hub, where each region has a hub run by local volunteers who spread the love, passion and enthusiasm for health technology in the best way they see fit. So a little bit more, they try and support the community, as well as by being extremely organised, by education and mentorship, promoting positive effects of inclusion and technology, encouraging broader participation at meetings and events, leading diversity and leadership, and having fun. And they cover all forms of innovation and in technology, which you can see up the list up there. Oh, I didn't mention their sponsors. They have kind of national level sponsors, Samsung, System C, BT, NHS Digital. So basically, I'd encourage everyone who's come, and we're going to be encouraging lots of people who obviously aren't here yet today, to get involved. You can join at the website up there. We're very active on Twitter. If anyone's not on Twitter, you should be on Twitter. Or you can just reach out to me or Catherine or Michael and get involved. It's all volunteer-led, so anybody and everybody is very welcome to get involved. And as someone asked me, oh, well, I thought this was just a women's thing when they looked it up. It's like, no, it's for everybody, please. If you want to be involved, basically. So, yeah, great. So Michael's going to come up and introduce our speaker. I just wanted to say one quick thing about how we're going to do tonight, how we're going to run it. If during this, we're trying to make this a really friendly and open environment and discussion space that's really, everyone feels safe to have an open discussion. So I'd encourage everybody in the room to think of at least one question to ask. And then we're going to do a little bit of structured networking and things afterwards, which we'll explain later. But now over to Michael to introduce Elizabeth.
Thanks. So Dr. Elizabeth Brooks works with me at the Digital Health and Care Institute. She's joined GSA in 2013 and has been design director at DHI. She also leads teams between Glasgow and the Forest campus for GSA in a variety of different modes of design thinking and design. And she also has a background in commercial software for about 20 years before coming back to the UK in academia. So Elizabeth, thanks very much for agreeing to talk, and I'm really looking forward to hearing about your work. Thank you. So there's two mics, one for the live stream and one for the PA.
Oh, that's completely intimidating, having two mics and not one. So you all seem terribly far away, actually, but and I do tend to move when I'm talking, so that could be a bigger problem than you being far away. So, Michael, thank you very much for the invite, Michael, and thank you for the sort of introduction. And I've got two. It's okay. Do you know what we'll do? We'll just pop them down there, and I'll try and not move far enough away that it's going to clatter onto the floor, or pick them up. Yes, yes. And everyone's going to see a picture of my dog now. No, it's a very good picture of my dog. No, we're not going to see a picture. Oh, you now set it up so that the screen's up there. I'm going to talk while that gets fixed. So, as Michael said, I was actually having a bit of a sense of a sort of personality clash this morning, because here I am being employed by an art school, giving a talk in an art school, but at Edinburgh University, which was actually where I got my first degree in ecology. And you're all sitting there going, what does ecology have to do with any of this? And particularly to do with being a design director of the Digital Health and Care Institute. Well, it was a very windy road that brought me here. And I feel that after Catherine's introduction, I'm a whole sort of bit of diversity all in myself here. Because I started off in ecology, moved into, satellite image processing, actually. And then moved into computing, commercial systems. I worked out in the States with Oracle. So big systems, worked out did a couple of years in South Korea with Samsung, and did a whole variety of very, very interesting stuff, and then came back and moved more into health. And then I moved into the art school, and oh my goodness, that was a bit of an eye-opener. It's all been a bit different, and I've had 5 years of getting used to that and telling lots of people at the art school that actually software designers are designers. So I don't know if that chimes with anybody out there, but that's certainly a conversation that I've had with members of Glasgow School of Art, and trying to say that actually designing a piece of software is harder than designing a chair, which that became a very heated discussion, I can tell you. It really did. My point there being that when you say, I'm going to build you a chair, the person at least has an image in their head of what they're expecting, and they know what it's going to do. Whereas when you're designing a piece of software, you often have neither of those factors present in the person that you're talking to. So from my point of view, I would definitely, I'm going to talk for a little bit longer, I would definitely say that the value in design, particularly in the tech push, we're not going to see a picture of my dog, are we? No. No. It was a very lovely picture of my dog. It had another dog sort of biting its tail. But oh, there we go. Excellent. So, right. So I've given you the introduction already, and oh gosh, I thought something had happened, like the dog had suddenly appeared. No. So what I'd like to talk to you about is the role of design within technology and health systems, and I'm going to give you a very personal view of this, so feel free to have a question, generate lots and lots of questions. It's a bit intimidating being told at the start of a talk that everyone has a responsibility to actually generate one question each, but I'll go with that. I'm going to give you a very personal view, so feel free to disagree, and definitely feel free to discuss. So, what is the future for digital healthcare? Well, I think most of us in the room, because we're here, we probably think it's quite bright. We probably reckon that there's fantastic stuff happening out there with the web. There's fantastic stuff happening out there with monitoring stuff, kit, all sorts of tech out there. There's so much more prevalent. There's so much citizen-enabled healthcare. There's so much talked about self-management and all sorts of things. However, when we actually talk about implementing that at scale within the National Health Service, quite often the reaction we get was, oh, but it's really complicated. And it's complicated for a number of reasons. We have quite a fractured model, and this is very historical, and it goes back a long way. We sometimes have a lack of mutual understanding. So we're clinicians and planners and GPs and everybody who's involved in delivering this health and social care. Quite often they understand their own systems and their own area very, very well, but they probably don't know what's downstream of them and what's upstream of them. And that obviously can cause problems. We have a legacy of really quite closed IT systems. Don't get me started on that. We have an attitude to risk, and I'm talking here about more of a cultural attitude to risk and risk within healthcare. Again, that's a big topic. And one of my soapboxes, which is measurement. We choose what we measure in the system, and that in and of itself will promote certain behaviours within the system. I'm seeing nodding heads. These are all really, really big topics. Not going to delve into them too much. And the motivation for change. What is motivating our change? Is it because we've got a different cultural approach? Is it because there's been something in the newspapers, as we've had recently with lots of, well, some quite critical and desperately sad situations in England and a couple of hospitals? Is it that kind of thing that's prompting change, in which case is it then coming at us a wee bit too fast? And sometimes that's what the future feels like. Rather than that lovely bright picture, it sort of feels like, oh, I'm going round the corner, I'm really not terribly sure what's at the other side of that. And in response to that, I love this quote from, gosh, I haven't my glasses on, Ralph Kaplan. And the quote is, thinking about design is hard, but not thinking about it can be disastrous. I would even put is disastrous. I was talking to somebody in Scottish Government this week, and we were talking about what design is. Now, my take on this would be design is actually thinking about something before you do it. And thinking about it might be building something, it might be drawing it out, it might be talking about it. There's lots of different ways that we do it. We're all designers. You don't have to have designer in your job title to actually be a designer. And it's not just about the aesthetics. It's about thinking something through to a point where you know what's going to happen when you actually implement that change. And that could be that you realize that if you change X in the way that outpatients' pathway is changed, it's going to have a knock-on effect that radiologists are now going to be swamped and there's going to be too much testing, or something like that. So, going on to a much brighter topic, what do we do within design within Digital Health and Care Institute? What I'm going to do is going to romp through quite quickly what we're doing within Digital Health and Care. And then I'm going to talk to you a little bit about the Scottish Access Collaborative, which is the project that I'm working on now with the Scottish Government. So, what we do within the design team within DHI is we do a lot of work designing with communities. So, co-design, participatory design, if anyone sort of is in that sort of area, they'll recognise those terms. We do quite a lot with pathways of care, and I've got a couple of examples a little bit later. We are very much into looking at that holistic system of health and social care and well-being, so it's spread across the complete spectrum. And then obviously living well in the community is another area that both DHI is really focusing on. And some examples of how we do that, I've picked up some pictures just to illustrate the range of the approaches that we take, because this is, if you're a designer and you're a one-trick pony, it will only work in certain circumstances. And I know that the work that we're now doing with the Access Collaborative, we have workshops where we have very senior consultants, we have nurses, we have patient reps, we have planners, we have a whole stack of people in there in the room, and we've definitely adapted our approach for that. One approach does not fit every single circumstance. But however, having said all of that, this is an example of one of the approaches that we've taken. I think this is from Nestus, and we have a laser cutter in the office. Oh my goodness, that laser cutter gets used a lot. So one of the things that you'll see from the GSA is a lot of the stuff gets been done on the laser cutter. This is mapping out, and you can see we're actually mapping out but in 3D, whereas here we've got mapping out, but mapping out using pathways, and it's probably extremely blurry for you, but it's just mapping out pathways and where the data flow is. That's something that probably, if you're from a computing background, looks an awful lot more familiar. This, on the other hand, is a piece of work that we did for the outpatients for Scottish Government, where we're looking at different perspectives and what's the experience, what's the pathway for these different personas, or these different people who are sort of coming through the system. In contrast to that, we also do actually mock up whole environments, and here you can see where we've mocked up what would be eventually a digital solution, but it starts off as a paper, and that would be one of my sort of maxims: always start with paper. There can be a real pitfall in even starting up with a digital, and this is, see, I'm going to try and be contentious here and see if I can get a question about this afterwards. But even starting up with a digital, a wireframe of what you're going to build implies a certain advancement through the process, and particularly the thinking process. If you really keep the fidelity very low, and if you even just have it written out on paper, you've got that possibility of other options coming up. It's that whole thing about not locking down ideas before you're ready for them to be locked down. And then if we just go through, this is a very quick overview of the kind of projects that we've got, particularly from a technical point of view, actually on the go at DHI at the moment. So a colleague of mine put this slide together, and it's always very dangerous to use somebody else's slides, but we've got these 6 particular areas that he's concentrated on, which I'm sure are all very familiar with to everybody in the room. But if we take them just one at a time, the personal ownership of data, that's AF, and if anyone has a question about AF, they need to be talking to Joanne. I've completely lost you. You're at the back. Who is at the back, who can also, if you've got any questions about ScotCap, will also be able to answer any of your questions about ScotCap, about the exchange. I think we also have colleagues in the room who are actually working on that. Balancing system, down to point 3, balancing system and user needs, exchange layer, modern outpatients, that's the work from the flows that we went through. Creating data only once. These are all just really good rules to be applying. Predictive and proportionate care and trust in distributed data. Next-gen asthma, picking up that one, that's very much a future. So that's 5G, it's very much in the more the research realm than in the implementation. So going through those, AF and ScotCap are actual products and solutions which are out there now. Next-gen asthma is very much out on they're out on the horizon, looking at what's possible. Future of care is something that's much more about the sort of philosophy. How do we want health and social care to actually work in the future? And diabetes and modern outpatient are both projects where we've engaged in a certain area and are giving advice, particularly to NHS and Scottish Government. So moving on from that, I'm going to very quickly go through the Scottish Access Collaborative. Now, this is a piece of work that we were asked to bid for at the end of last year. In fact, I have a vivid memory on the 22nd of December when everyone else had gone on holiday, putting the final touches on this proposal and getting the verbal okay for it, which I can tell you did really make my Christmas. Scottish Government have asked us to do these design workshops, and I think there's a real sort of leap of faith, a little bit of a leap of faith there at sort of coming in and saying, yes, you know, you go and do this. We've got these really a fantastic combination of diverse, thinking back to again why we're here tonight, that diverse group of perspectives in the room, and all tackling one problem, all trying to understand each other's perspectives. And all of the things that I was talking about before are at play in these workshops. It's all about understanding each other's perspectives, understanding what work we're each doing and being able to communicate that, and yeah, just getting on and understanding each other. And some of them are actually quite fun as well. Well, yes, they are. So there is a portion of money that's been set aside for the implementation of the ideas that come out of the Access Collaborative. But the aim for the Access Collaborative is to sustainably, and that key word there is sustainably, to sustainably improve waiting times for patients waiting for non-emergency procedures. So here we're basically looking at, if I could paraphrase dreadfully, that pipe, the outpatient's pipe, which is currently pretty much full, and looking at making sustainable changes which will reduce the stretch on that process, which means that we can build a little bit more flexibility in there. And the way that we're doing that is the first step, and this is actually, I was really interested in sort of this is the data mining and stuff like that. One of the things that I could share with you that we found from our first workshops, which we started in March. So we started in March, we've completed cardiology, and we're working on the report for cardiology, and we're already working with urology and gynecology. And one of the things when we started this process was, you sit down with the great and the good, and you go, well, what happens to the patient? Do they get from here? How do they get from? And the answer that kept coming back was, well, it depends. Well, it depends on, and there were all sorts of reasons what it depended on. And we had a bit of a light bulb moment when we said, you know what, we're not going to do it on the basis of a patient pathway, which is very undesignerly. What we're going to do is we're going to have a look at what the most common symptoms folks present with onto that outpatient's pathway, and then we're going to try and map that pathway for those symptoms. And I have to say that has worked for us really well. We got down to 4 symptoms for cardiology, same thing for urology, and same thing for gynecology. And it seems to sit really quite nicely within the mapping process. So if you take nothing else away from tonight, just keep that at the back of your mind as an idea of an alternative way to think about those patient flows or clinical pathways. So one of the things, actually, and this is coming back to something actually that happened today. I was having a discussion today with a colleague from ISD, and what they've been able to do, which it was just done today, so I don't have a picture for you, was in that 90-character field in the Sky Gateway referral, have a look at what are the most commonly occurring names or words that appear in those 90 characters on the referrals coming in. Now, that sounds from a data mining point of view like, that's interesting, but, and I don't know exactly what we're going to get out of it, but it's the kind of thing that doing that rather than doing one of a sort of a much more brute force measurement may actually yield some very interesting feedback. So it's that, in the research point of view, I think what we're doing is we're going in and just asking questions. We're not terribly sure where we're going at this point, but we're asking the questions. And I think that's another thing that if you're curious, just go and do it. Once we've done a bit of background, we then do mapping. And that mapping is in order to know where to ask the questions. And this is, I would say, absolutely central to the message that I wanted to get across tonight. It's not about the tech. It's about which questions we're asking. Are we asking the right tech? Are we asking the right questions? Because invariably we can develop the tech to answer those questions. The problem is that we're not always asking the right question. So the mapping is really important so that we get that end-to-end view of the system, and then we can work out what questions we're going to ask and then develop the solutions that would be appropriate to those questions. Now, when the groups come in, it's like those greyhounds. You know the greyhounds that are in the boxes and then they put the boxes up and the greyhounds are straight off? It can be a bit like that at the beginning of a workshop because everyone knows what they feel the solution should be. And you've got to rein everybody in and go, do you know what? We're just going to actually sit and do some mapping first. And quite often what you'll find is really clever people have worked out how to improve what is essentially a flawed and broken system that they're working in. But maybe the solution is actually deeper, and what we need to do is to change some of the ways that we're working and then add those improvements on top of that. So who we actually have in the room when we're doing this is, it's national. So we attempt to get coverage from all of the 3 regions. We have primary and secondary care, and this is absolutely vital. The GPs have been great that we've had, as are the consultants, but you really have to have both of those in the room. Consultants and nursing staff, particularly nursing staff, like for example in cardiology, where you have specialist nurses who have quite different roles. And then the service planners, absolutely vital. And there have been so many moments when the service planner goes, no, actually that's not how it works. And it's that moment where suddenly everyone's gaining that common understanding and you're able to have that conversation about, yes, but how do you want it to work? How would it best work? What's the best way for it to work? And we, of course, have patient reps as well. I've got a couple of slides to finish off. One is, this is Alan Hunter, who's the Director for Performance and Improvement at NHS Scotland. And this is just during one of the workshops. It's a wee bit grey, there's no Lego, we haven't found that has worked very well with this group. And as I said, we sort of tailor what we're doing to the audience that we've got. And even the output can look just a tad scientific and less art school. This is one of our intermediary diagrams. It's not our final diagrams, but the importance about a diagram like this, and this comes back to coming from ecology and ending up what I'm doing now. Because the whole thing about ecology, as opposed to botany or zoology, botany and zoology are both disciplines which describe what's out there. Ecology is something that describes the links between what's out there. And this is what we're doing here. It's not about what's out there, it's about what are the links, how are you working together, what happens between this point or this person and this other person. How does it work? How does it balance? How does it self-regulate? Which actually quite neatly comes right back to ecology. So it's amazing how I'm finding that I am actually using quite a bit of the stuff that I learned right back when I was at Edinburgh University a long time ago. And I'm actually applying it to what I'm doing now. So to sort of wrap up, I would say that in the diversity stakes, we do need people in health. We do need women. We need women in IT. That's absolute for sure. But we need so many different perspectives to be able to group together to deal with what is a national challenge. And without those different perspectives, we're just not going to be able to come up with the right answers. There we go. That was... Would you like one microphone or two, or?
I think we have to be together.
There you go. Go for it.
Thank you. Thank you so much. That was amazing, brilliant. And I think Elizabeth was a little concerned that I was going to make everyone ask a question one after another, but I'm not going to make you do the work. I'm going to make everyone else do the work.
Oh, excellent.
Because we're going to try something out where I would like everybody to find someone else near to them who they don't know, so in pairs, and to talk about the questions you've been thinking about. So many questions I'm sure you'll have. And try and figure out in your pairs, what do you think are the most important question, is the most important question you'd like to ask Elizabeth, or the most important point you'd like to draw out in the discussion? So we're going to have 5 minutes of sort of pair discussions, and then we're going to bring it back and do general questions for Elizabeth, and you get a break for 5 minutes.
Excellent.
So. Right, find someone you don't know. and I think Michael is going to come up and chair and sort of field the questions and chair the session, if you like. I'm going to make you do some work now. Yeah, that's on. You've got that. You've got pockets, so you could actually put that in.
Michael, repeat back the question. Sure.
See, they should design microphones for people who don't have pockets, which is usually women.
So has anyone got a question they'd like to start with? You get to use this very fun box. Yeah, thank you.
There's something very strange about it, yes, about the usability of that, yes.
Are we showing this?
Journey as well as going to and coming back to equality and dance school, so that's really interesting. I suppose my question goes back to the same aspect in terms of, you mentioned quite a lot that people from different services and different experience and different job purposes need to come together to have an innovative design. What my question is that when you invite or have people from various either walks of life or sectors, they bring their issues and problems with them, so they could provide their experiences. But how do you overcome the cultural barriers that people face in their organizations, and how do you design a streamlined process which addresses those various issues?
So just to repeat that for the live stream, people from different backgrounds are coming together to innovate. They bring their own baggage and problems, and how do you overcome them when you're running design?
Right, so I think probably we can split that out into two different areas. One would be getting people to gain a common understanding, and I am now completely convinced that it's got to be visual. Whatever you do, it's got to go away from writing blocks, reams and reams of text, and drawing something out is the only way often that you actually gain an understanding of what the person understands. And it's only through, particularly in these really complex systems, where you draw it out and you go, hang on, that patient's actually had that test done twice. Why is that? And then you get the whole group going, well, why is that? And then that's when you start getting the conversation happening. So I am completely convinced that visual, and it doesn't need to be flash, it doesn't need to be clever. If nobody has used Magic Whiteboard, which is the stuff that's up on the doors there, go and invest in some, because it's absolutely great. You can plaster it on windows, you can plaster it on walls, and get a number of Sharpies and just draw stuff. That's the best way of getting the understanding. The example that I would use, I'm sure people have come across, is game language. So if I'm playing football and Michael's playing rugby, and I say that was a really good penalty, I could be talking about the ball going under the bar, and he's talking about the ball going over the bar. And that's just a lovely example of how that happens. You know, it happens so often when we say something, and then the other person, we don't realise the other person's actually understanding something completely different. So visual, and that's what flushes out the assumptions. The second part of it is, how do you actually take that back to the culture? Well, I think the visual, again, is a really powerful tool. So one of the things, particularly in the Access Collaborative, is we see the mapping process that we do as part of the output. So from a research point of view, it becomes an artifact. It becomes something that's actually produced from the workshops, and it becomes a way of describing and explaining what's been happening. But you can't do it without senior buy-in and well, no, you probably can do it. Bottom up does work, but it's really so much helped by having that senior backing. And I think that we've found that as well with the clinicians that we've spoken to. If they've had the backing of regionally or at their board, they've been given quite a bit more latitude. Also, the clinicians who've been in absolute crisis, where the system really can't cope, they've also, because they've been given a bit more latitude to innovate. Yeah.
The nice thing is you can throw that, actually.
that this is going to work. I'm really interested in modernising the outpatient experience. Are you able to talk a little bit about that? Because I think it's a huge inefficiency for patients and for staff to turn up for a 1 hour appointment and it takes only half of a day.
Yes. So I'm interested to hear a bit more about the modernising outpatient programme.
So I would direct you towards this very lovely document called The Modern Outpatient. If you go onto ScotGov, you'll find it on there. And there's a lot of guidance there. They're quite aspirational, but there's a lot of guidance there on what the Scottish Government sees as being improvements. And I think it's stuff that would chime with all of us. It's the pitching up for a 5-minute meeting when you come all the way from Stornoway, for example. And within, there's an actual group called the Modern Outpatient Group, which works underneath Alan Hunter, and they have a number of ongoing projects. So I'm not going to have the complete one, but there is a project which is about virtual consultation. So we've also done a project about virtual consultation, which unsurprisingly came from the Highlands, where obviously folks are travelling a much larger distance at much more inconvenience for what can be just a regular appointment. They've had a couple of, if anyone's been aware of CivTech, there's been a couple of CivTech projects that have gone out under the modern outpatient auspices, and I think it's not just been CivTech, there's probably another couple of calls as well. And then I think what's going to happen is what we're doing with the Access Collaborative, which is looking at that process of the outpatient, is there'll be some work that gets kicked off from that, and that will fall within the same. So I think it's a nice mix of, some of it has been very technical, and some of it has actually been around sort of things like how do we get the electronic health record from here to here. Some of it's a bit of sort of thinking about it, and then what we were doing, which is much more system level, and looking at innovation in that context.
I knew we were going to go over there next, sorry. I promise, sorry.
Oh, thanks, and thanks very much for your talk. Ecology is even higher up my agenda now than it used to be. So, our question, I suppose, is about suboptimal solutions and risk. And we started your excellent talk by talking about what was happening down south, and obviously people were going into quite a risky environment without necessarily knowing it, because it wasn't designed in, but nonetheless it was pretty risky. And we wondered about new design, and if you're doing something new or innovative, there's always a higher level of risk, generally, than doing something the same way. And I suppose the culture of risk and being prepared to be explicit about that risk, but nonetheless, if you want going live into that environment, and I think we appreciate that's not just a medical issue, it's a political issue and a social issue, but being honest about that, and how do you drive change when there's more risk involved?
So that's around about the approach to risk, and particularly through innovation in health. I think you hit the nail on the head when you said it's about transparency. So if I go back to when I was managing risk within big projects in like Oracle or Samsung, the thing that really annoyed me was when people described risk just in this might happen and that might happen. Basically, you're writing a risk log so that you've covered your back in case it happens. That's not about managing risk. Managing risk is about saying, this might happen, but also this might happen if we don't do anything, and we choose to select this option and not this option. So it's about that, having that honest dialogue about what may go wrong. And obviously in a health context, the stakes are so much higher, but we still have to have that conversation. And you're absolutely right. I think it's one that we have to have at a societal and a sort of almost cultural level. It's certainly something that we're hearing about. It might be that, particularly and I'm looking more at Michael here, it might be something that I think in the training, the way that doctors are being trained, that maybe the approach to risk has changed a little bit. It's certainly something that I hear in the workshops that we have from the older colleagues. They maybe have a little bit of a different approach, and particularly when there's the illusion that risk can be managed by testing. Yeah. So that it's that medicine is that combination between testing, between measurement and practice. And practice is something that you build up through experience. And it's that tension between those two. But I think you're absolutely right. If we don't have an honest discussion about it, we just end up being so risk averse that, you know, it's sort of, this really fragile system isn't broken yet, so I'm not going to touch it just in case something breaks. And without that conversation happening, I don't think we're going to have innovation, to be honest. Yeah.
There's a bit of reluctance when it comes to apply some mathematical algorithm to healthcare. Mm-hmm. Does it apply also to you? Because I know that in the Food and Drug Administration, for instance, it is a kind of restriction to apply some technology like artificial neural networking. Are you more open to explore those technologies, design process?
Yes, I was. So that was talking about sort of applying algorithms and I suppose machine learning and artificial intelligence is really what you're talking is maybe where you're heading with that question, and can that be applied to healthcare? Have I understood that correctly? Yeah. Yeah. So I would say definitely there is a place, absolutely. I think particularly when we're talking about data mining, there is a place for decision support, absolutely for sure. But the first step has got to be that clinical discussion, which says, if this is the diagnosis, where should this, you know, what rules are we actually going to apply? Because these algorithms can't be magicked up out of the air. And I think quite often what we don't have is we don't have the rules. And that's why stuff sometimes doesn't work. Because we haven't had those discussions like around risk about, well, you know, this person has chronic pain and, you know, we actually can't help them. What are we going to do? So it's having those honest discussions, which quite often I think they might be, well, certainly in the area that I'm working now, it's a conversation that needs to happen between primary care and secondary care. And without those rules, it doesn't matter if you put a smart piece of software in there, it doesn't have the rules in order to be smart. Now, there's a different place where we're talking about things like data mining and profiling and pattern recognition and that sort of element of where you can automate it. So my axiom would be get the software to optimize what people are bad at and get the people to optimize the stuff that the computers are bad at. And thankfully, the two things do tend to be different. So for a GP, getting a piece of software that is going to automatically, based on the symptoms that they've put in, pull up the guidance plus what's available locally plus NHS Inform all into one little package that you can hit the printer and go, here you are, Mrs. Jones, there's some guidance for you and some background on what I think you've got. Yes, that's a really great way of using it. But using terms like machine learning or particularly artificial intelligence in this context, if you don't have the rules, is I think really quite dangerous because it gives you the illusion of control that you don't have.
Anyone else got any questions? We can make this probably the last one, I think.
Thank you. This is going to be an attempt at a kind of a joint question comment from three new colleagues, myself and two new colleagues, Andy and Nicola from Microsoft, myself from the NHS, and I think thanks for your excellent presentation. We found, I think, a very similar theme across our quick chat, which was me from inside the NHS and in this case two colleagues from Microsoft. How do you help to lower the barriers and the cultural, organisational, structural barriers of you know, organisations like, say, Microsoft or any tech developer trying to get closer to patient experiences and clinical responses to that, and I myself experience these huge frustrations of blocked, even trying to look at a website. What are some of the tactics and approaches you found help to make that dialogue?
Closer to those rules that you were intending.
Yes, yes. So if I can see if I've got that right, so it's how can like a big company like Microsoft get closer to what's actually needed within the NHS? Would that be a fair reflection of the... Go for it. we've got some clarification happening here.
Because it's three-way now, I might as well put my tuppence.
Go for it.
So, my thoughts were, in terms of all the work that you've done there, in terms of the pathways and the mapping, how do you hand that baton on to someone who can then do something creative or bring down barriers with that?
Yeah, right. So it's how we also hand that on so that it becomes something that's implementable, yeah, which can then be understood by a big company such as Microsoft. So I think the first point I would say is starting with the problems would be the first thing. Not what you can offer, but where the need actually lies. And then the challenge there is how do you find out where the need lies? And I think sort of a group like this is a great place to have that kind of discussion, and there are other places where those sort of discussions can happen. Go for it.
Under EU law, for the time being, there is an opportunity to do exactly that under which is called innovation partnerships, and it's a procurement methodology that we do not use in Scotland. There's 26 innovation partnerships elsewhere in Europe, and Galicia is extremely good at using that in identifying the problem and then sharing that content with providers to co-produce a solution that actually meets the requirements. We don't make use of that, and we should make more use of that, and it's perfectly possible, and that's something that we're doing within DHI to use that mechanism that's available to us to actually change the way that we procure services and create that route to commercialisation for small to medium enterprises, so to support that economic development within Scotland as well, and also for bigger corporate companies to come in and work alongside or work with SMEs as well. So it is available, but we're just not making use of it and not everybody knows about it.
So I suppose that sort of just recap there, as Joanne has so wonderfully prompted me there, that there are structures in place, but there are also institutions like the Digital Health and Care Institute, which is designed specifically to bridge between academia, third sector, public sector, and business, and can broker that kind of discussion. I think to round it off, though, what I would say as well, I think maybe in part of what your question maybe is about that being implementation ready. And that's something I feel really passionately about, having worked in software companies where quite often, I know it happened at Oracle, because I would imagine it possibly happens at Microsoft as well. You have the marketing department, the sales department, who come up with a brilliant idea and lob it over the counter into the development group, who then are sort of having to work out where it's actually come from. I personally feel very passionately about anything that we produce from a design perspective needs to be ready to be taken to the next step. And for that, you need to work with the next step to work out what are the barriers to implementation. And within Scotland, we have barriers in that we have local systems, we have local procurement within the NHS. It's a splintered system. How do you get that conversation even happening at a national level? Who do you need to talk to? And a part of that, I suppose, is just asking the questions, being curious, and keeping on. I had exactly that point where track care, well, you'll have come across this being from the NHS. Track care kept coming up, and I went, oh, that's interesting. Let's have a look at that. Oh my goodness. My goodness. I had a wonderful session from Paul Campbell, who took me through track care. But I'm better informed now, having had that. So it's that being curious about learning more about the environment that you're working in, and sort of challenging your own assumptions maybe as well.
Another round of applause. Thank you so much. Thank you. So the next part of the evening is very unstructured. It's really just a chance for people to network with a little request. Around the room at the back, you'll see there's these white sheets that Elizabeth talked about. And kind of, if you could maybe pop into groups of 3 or 4 or 5 and just write a few answers to the questions that are above those. on the post-its and pens that you'll find around the back. We're not going to say any more about it because this is really just networking, but maybe it will stimulate a few thoughts. And also we're going to write that up after the event and just send it all out to you, because I think some of the answers will be really interesting. But otherwise, help yourself to a few more drinks, and we've got this room until 9 if we want it, so you're welcome to stay. But otherwise, thanks very much for coming. We really appreciate it.